Hello, everyone. This is Stan Skinner from the International Society of Intraoperative Neurophysiology, where I chair the Evidence Task Force. Today, we're going to discuss real-time interaction with the new neuromonitoring form. There are 4 sections to the form. The first section is on preliminary data, which would include the monitoring date, type of institution, the care model used, planned anesthetic, patient deficits, and imaging. The second section has to do with the acquisition of MEP, motor evoked potential, and SEP, sensory evoked potential data. The third section is to do with alarms. 3 possible alarms can be listed for both MEP and SEP as well. So a total of 3 MEP and 3 SEP alarms could be listed in the form. Questions are asked with regard to definitions of warning criteria, anesthesia and technical issues, and surgeon acknowledgement. In addition, questions on context of the alarm, intervention made based on the alarm, and recovery. Co-diagnostic section is also listed so that we may know whether C-arm, interop, CT, robotics, or other surgeon-driven automated neuromonitoring devices are used, and whether or not a wake-up test has been performed either as part of an alarm or electively sometime during the case. Now let's move on to the website itself for EUROSPINE. And let's say we've entered our credentials and we want to search for the medical record number of the patient we're monitoring. So we'll hit search, select search, and enter the medical record number of our test patient, which is 789321. Search. And we find the patient, and note that there is a case report form available. We hit the magnifying glass icon to view details. And we see there is a surgeon form that has been entered, although it's incomplete. Now, as I indicated in part 1 of this series, we can add a form. When we do that, taking just a few moments, we will see a drop-down list of forms, and we will highlight the intraoperative neuromonitoring form and select that. First thing we do is enter the date, which is 09 January of 2025. So January 9th, 2025. Having entered that, we can now begin the form. First is neuromonitoring specified as, well, the vast majority of instances, our expectation will be in-room neuromonitorist independently recording tests. At times, there may be also the surgeon use of a handheld or automated device. And the form is not really meant for surgeon-only handheld or automated devices. So let's enter in-room neuromonitorist independently recording tests. Next, questions on the institution hospital. Total number of operating rooms, not just spine surgery operating rooms, 21 to 30 amongst the possibilities. University affiliated, yes or no? We'll say yes. Neurosurgery and or spine fellowships. Well, we'll say not those. Model of care. The model of care is a long drop-down list that basically includes a PhD or MD doing everything in the case, is in the room the entire time, and basically does the monitoring. The next selections have to do with a technologist or physiologist in the room, but also with an in-room PhD or MD neurophysiologist who may be in and out of the room. The next selections have to do with the technologist running the case, but the MD or PhD is around the hospital and immediately available for questions. There are questions regarding technologist or physiologist directly supervised by the surgeon, no PhD or MD neurophysiologist. And then there are a couple of questions having to do whether there is an MD or PhD neurophysiologist out of the hospital and remotely connected to the case. And so in this case, we'll say there's a technologist with an MD as a part of the case, for example. Planned maintenance anesthetic. We're going to be doing MEPs. The preference would be total intravenous anesthesia, but the anesthesiologist may insist that some inhaled agent will be part of the plan, so you could put that in there like that. Pre-op limb or walking neurological deficits, we're going to say yes. Sensory deficits, so we're going to say this is a patient with cervical spondylosis, with high-grade stenosis at C4 through C6, with numb hands and gait imbalance. So we'll say the sensory deficit, we'll say is yes. And we'll say it's both upper limbs. When more than one answer is possible, you may have to click outside the drop down in order to move along and get the other questions visible. Motor deficit, we're going to say yes. I think we mentioned that both lower limbs had some gait ataxia. Say yes. And there's further selections on that. The patient can walk with fair or poor coordination. We'll answer that as opposed to cannot walk or using an appliance. High risk findings on imaging. There may be none, there may be other high risk, but we're going to say there's a T2 intramedullary signal present. Click outside to go on. We could also include severe absolute critical stenosis, for example. MEPs monitored. We're going to say yes, but what if we said no? Well, if the answer to MEPs monitored is no, there is an immediate drop-down list below that, which needs to be addressed. Among the answers are not attempted because not indicated, not attempted because of patient factors, not attempted because not ordered or declined by the surgeon, attempted, but MEPs not recordable. So we'll just stay with not attempted because not indicated. Now, there may be more than one reason why MEPs were not monitored. One is not being able to record them. But that does not imply that they're never recorded. So under warning criteria, under major MEP warning criteria and definition, that still needs to be filled out. So under spinal cord MEPs, we could say 50%. Under root or plexus, we can say 50%. There are other choices as well that we'll address again in a few moments. And that'll take care of that issue. But what if you never record MEPs? The way to address that is to answer other on the spinal cord definition and other under the root or plexus definition, and then specify, as it says here, and I'll rewrite it, none. That's to specify other. That's the way to address it if you never record MEPs for any patient. Same for SCPs. But let's go back and say, yes, we are monitoring MEPs. There'll be other questions regarding MEPs. Total intravenous anesthesia. So remember we answered earlier about that question about the plan. And there may have been further discussion. and maybe it was decided that total intravenous anesthesia was the way to go. So you answer yes there. Partial or complete neuromuscular block, we're going to say yes or no. We're going to say no. When first MEP reported in terms of timing, there are several possibilities. One of them is after incision or later in the case. Another is after positioning, but before incision. We're going to say before and after positioning. Before crucial surgical actions, MEPs recorded from all limbs and myotomes that are at risk. We'll say yes. And the next question is, were they optimal? So there's a variety of ways of recording MEPs, from supramaximal stimulation to threshold. So we're going to say optimal is greater than 100 microvolt peak to peak. So we'll say optimal. Next is an estimate of the frequency of MEPs between the time of end of exposure to the closure of the case. The options are 6 or more bilateral MEPs per hour, meaning a left and right MEP counts as one bilateral MEP. We're going to say 6 or more per hour. Again, these are estimates. Maybe the surgeon is a little anxious about doing a lot of MEPs in a particular case. So maybe we're going to do less than 1 an hour, or 1 to 3 per hour. Just put down the number that actually is pertinent as you complete the form after the case. Were upper SCPs monitored? We're going to say yes. Recorded before and after positioning, we'll say yes. Lower SCPs, we'll say the same. And recorded before and after positioning. Trial to trial reproducibility, we'll say good. By the way, I forgot to answer trial to trial reproducibility for upper SCPs. Let's go back and figure that one, and we'll say those are excellent. Warning criterion. You'll be asked one time for the major MEP warning criterion definition for spinal cord. Let's say it's going to be a 50% amplitude decrease. Notice there are other answers, including disappearance or other. But let's say we use a very liberal criterion, 50% amplitude decrease peak to peak for spinal cord, and for root and plexus 50%. Then we move on. MEP alarms, context, action, or intervention and recovery. Was the warning criterion met? We'll say yes. Remember, this is a patient with cervical spondylosis, high-grade cervical spondylosis with a T2 signal at, say, C4-5 in this case. Was the alarm anesthesia or technically related? We'll say no, in which case other questions occur. If I say warning criterion met and say it was due to anesthesia or technical, if I say yes, the other questions do not occur. That uses one of our 3 alarms for MEPs. But that's what happened. We worked, we talked to the surgeon. Finally, we found out it was a technical issue, and we needed a little adjustment in anesthesia, one or both, and we say yes. Add another alarm? Yes, let's add another alarm because there was another event. Warning criterion met? Yes. This time was it anesthesia or technical? We're going to say no. Was surgeon informed and acknowledged? Let's say no, just for our purposes. Surgeon deferred response or delayed acknowledgement. Not sure surgeon heard or understood the alarm. Those are possibilities in real-time cases. But let's say in this case, the surgeon was informed and acknowledged, yes. Warning criterion, limbs affected, we'll say both lower limbs. Click outside the field to be able to move on, because it could have been both lower limbs and say one upper limb or both upper limbs. Surgical context. Well, in this case, it could have been surgeon action or maneuver, inadequate blood pressure, perfusion, or oxygenation, unknown or other. We're going to say it was positioning right at the beginning of the case. The intervention was adjust or reversed, or actually was repositioned. Obviously, other possibilities are surgeon action, surgical pause, aborted surgery, wake-up test, or none. Complete or partial recovery. Well, we're going to say yes, and we're going to say partial recovery. Partial recovery means one or more of the MEPs did recover, but some did not recover. A complete recovery means all MEPs that alarmed recovered. If it's partial, then they didn't all recover, but some did. At another alarm, we're going to say no. SEPs, please select. Warning criterion, 50% amplitude decrease. The other possibilities are amplitude reduction from recent pre-change values. This was noted by David McDonald's SEP paper a few years back. But we're going to use the 50% criterion today. And these selections are very similar to what we saw before. So we're going to say warning criterion was not met. Co-diagnostics, C-arm was used. Three-dimensional CT or O-arm was not used. Robot-guided screw implantation, for example, not used. And there were no other surgeon-directed automated devices for neuromonitoring used, and a stagnaural wake-up test was not used. You have now completed the form. What we can do is either save it, and we get a signage saying save successfully, or submit the form. Well, that's the basic interaction with the new neuromonitoring questionnaire for Spine Tango. Thank you very much.